Good. So now we are at lecture 4. So this is the learning outcomes. Again, think about this. Think about this first. Okay, I'm still writing the answer. Okay, sorry. So the boundaries of the perpetual fossa. So we just mentioned all the names, right? The medial upper, the lateral upper borders is a diamond shape. Okay, and then the lower part, we have the lower. So the whole group here is the gastrocnemius, but on the lateral side, we have a more like deep muscles that actually form the medial lower border of the the gastrocnemius, as well as this muscle is called the pentaurus. So the borders here, and then the floor here is the distal femur together with the knee capture, and also a muscles which is very important for the knee action is called the popliteus. Okay. Very complicated content inside, right? But one thing, this is a good one. Now, when the femoral artery, once upon a time, it is still external iliac. When it pass through or underneath the inguinal ligament, it becomes femoral artery. And this femoral artery very soon will divide it into two, the deep femoral artery, and then we'll have the perforating branches, as well as the MCFA and the lateral circumflex femoral arteries, right? And that's all for the deep femoral arteries. There's still one or two remaining branches. We will touch on this on the next slide. But I just here want to record you. We still have a femoral artery, right? It passed through a canal, which is called the adductor canal. Remember that? Adductor canal. And this adductor canal, once it from the adductor canal and pass through this opening formed by the muscle tendons here, which is called the adductor hiatus. Once it passed through here, then the names change to popliteal artery. You know that the division or the division of the arteries are important, super important for the lower limbs, right? Because we talk about muscle contraction, so blood supplies is very important. Once it cross, right, the adductor hiatus, it becomes the popliteal artery. Okay, good. Now the major content. So the major contents here are the tibial nerve, and also we have the this one is not very obvious. This one we have the common fibular nerve, okay, the branches of the sciatic nerve, and also we have the small saphenous vein. So we have small saphenous vein. So this small saphenous vein is actually like will drain from the superficial layers will drain into the popliteal veins. Okay? And then we also have the popliteal veins and also its tributaries, right? And then we drain into the post-tibial vein, and then gradually like we get back to the femoral vein. Okay. And also we have the popliteal artery. So popliteal artery, remember the zonal the zonal differences. Once it crosses the pass through the adductor hiatus, it becomes the popliteal artery. Okay. And then we also have the lymph nodes. So here, I hope you can have an idea that this popliteal artery is actually very, very deep. You can consider this as just running on the surface of this part of the bone. Very deep. So that's why when you are asked to like feel the popliteal pulse, if you have it on the like extended knee, all the muscles are tightened, right? You cannot feel it. So if you have to do so, you have to bend the knee a little bit like this. And then you apply force so that you can find the pulse. This is the differences, right? Okay. For the femoral pulse, it is quite obvious because it's just right underneath the inguinal ligament. But this one, you have to bend the knee like this, and then you apply some compression, and then you can feel the pulse. Okay. Oh, this one you can try it on your roommate with his or her approval first. Better with third person next to you. Okay. You say that is for my experiment. Okay. Don't do it in some insidious area. Okay. Now then, it is important because when you do dissection, you will start to realize that actually this popliteal fossa is very filled with a lot of fatty tissues, a lot of fat. Okay, but what matters here is I want you guys to appreciate the arrangement of the structures from superficial to deep approach. Most superficially, we will find the nerve here, the nerve. You see that the nerve, and then you will then find the vein, and then next to the vein you will have the artery, and then right next to the artery, right underneath the artery, which is the popliteal surface of the femur. Okay, so here, can you imagine one scenario? If I understand that you like fracture, right? Many fracture injury, right? So think about if someone got a fracture, the site is at the distal femur. What you need to worry about if it is a total fracture, like here, or let me draw, okay? So it's actually you have to concern about is severe bleeding, right? But not the upper part. For the mid shaft, it's kind of okay. You may damage some of the perforating branches. But if you are having the fracture at least distal 1/3 or even the distal 25%, I can't remember the exact figures, right? The distal part here, when you have a fracture bone, you may also damage the arteries as well. Okay, just like when you revisit the upper limbs, the radial artery is at the mid shaft. So here is the femur. Okay. So, and think about it. If some people they are so muscular, and do a lot of the leg leg work, and they have a super gigantic gastrocnemius. You think about this head here. Now, this head here, if this muscle is so big, and then when you apply force, when you contract, it basically, you stop the blood flow if it is super powerful, okay? So that's why hypertrophic gastrocnemius head may compress the popliteal artery. It may reduce the blood flow to the leg and foot. And this syndrome, we call it the popliteal artery entrapment syndrome. You see the word entrapment before in upper limb. We also have similar one here. Here one, this one I think is more obvious for the power for the 筋肉人，我唔知點叫嚟嘅 ，very powerful man, right? And do a lot of the leg work. 即係隻腳好粗嗰啲咯。OK， 女仔唔係，女仔粗唔係因為肌肉啊，係嘅都係，世界冇肥人 OK， 得我係最肥嘅。先嚇，有乜所謂呢？ Then think about it. If we have such a movable joint, right? We need to work out the knee joint every day, right? You use it. Even though when you're sleeping, kind of you will flex your knee when you turn, right, on the bed, right? So how can we make sure that the leg and also the foot receive blood supply while we need to accommodate such a heavy workload of the knee joint, right? Flex and extend, flex and extension. So that's why we have another anastomosis. Okay, we have another anastomosis to accommodate it. So again, don't worry about memorizing every branch immediately now, okay? You will soon remember it all, okay? So, but first understand the logic here. So the knee, right, as I said, a very mobile joint. It relying on only one strict arterial blood supply is not ideal, not optimal, okay? So the body therefore create these anastomosis around the knee. Now, the branches here of the popliteal artery, right, and you see that it's actually connecting with these descending genicular artery, and then also with this descending branch of the lateral circumflex femoral artery. Okay, so these two, right, and then it form the anastomosis, and then now you can see that even though there is a blockage here, think about it, right, but there are still other blood supply that can nourish the knee. No matter we are talking about the knee joint inside or to supply the anterior side, anterior surface of the knee. Okay, so it is a collateral circulation that can maintain blood supply to the knee doing full knee flexion，即係隻腳接埋嘅時候啊。Okay. Full knee flexions, we still have blood supply. Okay. Okay. Or if there are any obstruction of the mid, so mid, it could be up to here, the mid femoral obstruction or the distal femoral obstruction like in here. Okay. While you still have other branches that can supply, right, the whole knee, okay, which is by the genicular anastomosis. Okay. And they are forming the anastomosis with the popliteal artery is with these two, right? The one in blue and here the one in pink, right? Descending genicular artery and also the descending branch of the lateral circumflex femoral artery. Take a look. It is from the deep femoral artery. Sorry, this is from the deep femoral artery, the origin. We say the immediate origin. Okay, immediate origin. Okay, good. And then this is the leg bone. The leg bone here, wow. Remember in dissection, do go to skeleton and take a look on the tibia, okay? So because the tibia is a very nice bone, anteriorly you can find a very sharp edge here with only subcutaneous tissue and skin. But even though if you are so choppy like me, obese like me, you still can feel the anterior border of your tibia. So you will still give encouragement to yourself, right? I'm not that choppy, okay? But on this side is actually only covered by the subcutaneous tissues, right? No muscle at all, okay? So that's why in this site is very prone to fracture if external force apply, okay? And remember on the tibia, anterior surface, proximal part here, we have a protrusion here. So this protrusion is called the tibial tuberosity. So the quadriceps, the patellar ligament, right, will attach to this site, right? It attach to this site. And then the tibia come with the medial malleolus at the distal end, which is on the medial side. And for the fibula, remember this fibula, we say that it is not the weight-bearing bone, but doesn't mean we can remove it. We still need to have the fibula, okay? Because to form the ankle joint, okay? So this one also forming the lateral malleolus. One thing, these two bones in the distal end here, they have a very tight junction, which is called the syndesmosis. Still remember the name? The syndesmosis. Okay. Here. Part of the fibrous joint, very tough one, the syndesmosis. I will have the name on L5, the lecture notes, okay? No worry. So this is the bones of the jaw, the bones and joints of the foot. Now this one, sometimes you may find it difficult. Yes, it is. And there are many joints, right, formed between different part of the bones. But let's take a look first on the two important joints. One joint here is called the ankle joint. The ankle joint, right, this one I'll call it talocrural joint. So this one is to allow us to do the dorsiflexion. You know what is dorsiflexion? You should know it, right? The dorsiflexion and then plantar flexion. Tiptoeing is plantar flexion, dorsiflexion. So a quick question for you. So do you think that when you are having the dorsiflexion or plantar flexion, which one allows us have a more stable ankle joint? Dorsiflexion or plantar flexion? Which one? Dorsiflexion should be like more stable, right? When you are tiptoeing, right? Usually you will feel like you have less support, right, of the ankle joint, right? So this is what you feel. But later on, we will see the arrangement of the ligaments and also the contour of the joint, right? So first thing first, so this is the ankle joint, okay? Talocrural joint, okay? And then we also have to take a look on two, or actually two groups of joints, but they are formed by three contact points. Okay, first thing first, we have the transverse tarsal joint. So these, now I try to make the color match with the name so that you have an easy reference. So we have these here, which is called the talonavicular joint, and together with this one, the calcaneocuboid joint. So these two all together, we call it transverse tarsal joint. We still also have this one, which is called the subtalar joint or talocalcaneal joint. All joints together, what for? Is for the inversion and eversion. So which one you feel like is more difficult to achieve? Inversion or eversion? The boys, when you go to play football, right? Or play the basketball, outside. So outside is actually because of having exaggerated inversion or exaggerated eversion. Inversion. Okay, so you have some ideas now, okay? And then I keep my promise. Is that 8 minutes? Is that okay for you? 但係我冇開電腦，你未開電腦啊？咁啊，你等陣啦，你。So then we will continue with the compartment, the different compartments of the leg. And this one, you have to think of select source, PC. Okay. Okay. So just now, you may confuse about the movement, unique pattern of like the movement, inversion and eversion. The boys, most of the time, when you feel like have a painful movement, will be like this. This is called the inversion. I-N. Sorry for my bad pronunciation. Inversion and eversion and inversion, okay? So eversion, You're pointing like the whole like this. And then, okay. And then if you turn to like 中國數目字八字點寫㗎？咁樣㗎嘛。So this one is inversion. Okay. Inversion, eversion, right? Don't mix them up. So down to the compartment of leg, okay. And what you need to border is quite a number of things. First, so we have 3 compartments, and then the bones here, the tibia and the fibula. Okay. So we have this IN here is called the interosseous membrane, same as what you see in the forearm. Okay. So between the 2 bones and with this interosseous membrane and also the anterior intermuscular septum, we have this green zone here, which is the anterior compartment. So we innervated by the deep fibular nerve, right? So, and also contain the dorsiflector and also the extensor of the toe. We will come to these one by one later. But here, one important point is one nerve, one life, one love, right? One nerve, one artery, one vein, most of the time here, okay? So here we have the deep fibular nerve, right? And also the anterior tibial arteries, okay? And then on the side here, we also have these compartment. We call it lateral compartment. This one only have a few members, right? They are doing the everter, so you have to know the definition. Everter, E. Okay, and then at the back we have a big parties here, which further divided into 2 parts: the deep group and the superficial group. The superficial group here, we have the gastrocnemius, right? And the deep groups here, we have the others, okay? So why I put a star here is that in theory, so every compartment, no matter for the upper or lower limbs, thigh or the leg, where we have compartment, so there is a chance to develop compartment syndrome. But which compartment is being like most susceptible to develop compartment syndrome? We always refer to the anterior compartment. So first thing first, it is next to a big bone, and that is not it doesn't have much space to expand, right? And you do the dissection, you can tell. Remember yesterday when you do the forearm, it's quite loosey. It's quite loose, right? You can simply work with the muscles, right? But you won't see the same things in the leg, particularly the anterior compartment. So we also have like a very thick fascia to surround the leg. Here we have the crural fascia, right? Very important to accommodate, right, or to make it better with venous return, blood return. So why we bother about the compartment syndrome? The pressure increase in the compartments can compress the neurovascular bundles. Say it then will lead to like ischemic cell death or some irreversible muscle and nerve damage. But then you may ask, why suddenly there is a compartment syndrome developed? So you can think of like here, very limited space, right? If you have bleeding in this site, think about it. If you have bleeding in this site, right? Or there are some bacteria like stay in this compartment, grow in numbers, producing gas, but you have a very intact, very tough environment here. No room, not much room for expansion. So then it will compress on the nearby nerve as well as muscle. So that's why sometimes, okay, so that's why we say that anterior compartment syndrome is the most common one among the others. And then it may require emergency incision of leg fascia to relieve compression. If you are fans of Grey's Anatomy, not the book, I mean the TV show, okay? Anyone are the friends of the Grey's Anatomy？有冇人中意睇嗰本書㗎？咁厚嗰本咧，我都冇再嘈啦。而家佢出到43定44 edition，43，it should be 43 yeah edition Bible, okay. So, but I'm referring to those the TV episodes. So you might see that in some episodes, that someone come in and they will say, he has necrotizing fasciitis, and then they have the light and then open the compartment to release the pressure. That's what we perceive like compartment syndrome in clinic, right? I mean, in TV show, okay. So now let's down to the lateral compartment. We do it one by one. Let's do a small size here first. The smallest one, the smallest one here is the lateral compartment. So how many members? Haha, only 2. So that's why we say small compartment. So we have the fibrillaris longus. So number 1 here. So this one is the fibrillaris longus. And then we also have the brevis here, like 2 brothers, right? They all swing, the long tendon, they all swing around the lateral malleolus. So that's why we say that the lateral malleolus here act as a trochlea, right, for the fibrillaris muscle. Okay, so the tendon like runs posteriorly, right, to the lateral malleolus. And if you take a closer look, actually in the leg, in the ankle joint, soon to be the ankle joint here. So you will see that there are some retinaculum, same as the upper limb. We have the retinaculum to hold, right, these long tendon in good position while accommodate, right, the action in between, right? When the upper part is contracting, then we still can keep the long tendon in good positions. Okay, so take about the nerve. It is supplied by the superficial fibular nerve. And then for the blood supply, this is no surprise. Only 2 members. No artery in the lateral compartment. So it's served by the perforating branches of the anterior tibial artery and the fibular artery. Okay, so this one is like they don't have their own blood supply. 靠黐嘅呢個 okay. Then I mentioned here is an everter compartment. So when you exercise these lateral compartment muscles, you're doing eversion. Or if you still can't imagine that, take a look here. So the muscle, the long tendon is actually from the lateral side and then descend and then across, right, the foot. So think about if this muscle contract in this way. So what would you do, right? You will actually like shorten this, right? And then we'll have this eversion, or you can take this as well. When the muscle contract, so the tendon will have the tension develop in this way, right? Now, at this part, you may have to remember these. I try not to be so examination oriented, but I do share your pressure. Okay, so if I can help, I will. So for this one, I expect you guys can recall the attachment site of these fibrillaris longus. In short, we call it FL. So it's attached to the base of the first metatarsal bones. Because this is important for you to understand these FL not only can produce eversion, but it can also help to maintain the arches of the foot. Okay? 1 bird, 2 stones. How many stones? How many? Okay, so there are 2, and then for the fibrillaris brevis, the attachment site here is the base of the 5th metatarsal. Okay, this one I hope you can recall. Okay, now so the major I try to put the actions right in terms of the importance. So this is the everter, so eversions. So they can also help to have a weak plantar flexion. What is plantar flexion? Plantar flexion, you will try to like 咁樣嘛，係咪？ Plantar flexion, plantar flexion, tiptoeing. Okay, so these FL and also the FB can also assist in doing this. Okay, and also support the lateral longitudinal arch. Next, then we move on to the anterior compartment. So there are 4 brothers together. 有一個收養返嚟嘅。Okay, so 4 brothers together, all together they do the dorsiflexion. So you can call them all together dorsiflector. Okay, dorsiflector. So think about the big brothers here is the tibialis anterior, TA. And then we also have the extensor hallucis longus, extensor digitorum longus. So where are they? Take a look. So this one right next to the shin bone, the tibia, right lateral to it, we have the tibialis anterior, the big brothers here. Okay. And then we also have number 2. Number 2 is here. We have the extensor hallucis longus. Hallucis means to the big toe. Okay. And then we also have the extensor digitorum longus to the remaining 4 toes. Okay. And then we also have number 4. Where is number 4? Oh, number 4 唔見咗. Oh yeah, here. Number 4 is here. Can you see number 4? A tiny muscle. Like this. Okay. So this is fibularis arteriosus. Yeah, the small one. Okay. So the nerve supply is the deep fibular nerve. And it is supplied by the anterior tibial artery. I want you to revisit this image here. If you can make a label. So this one is actually the anterior tibial artery. Wow, what that? So this one is the anterior tibial artery. Deep, deep, next to the bone, and also fine, right, lying on the interosseous membrane, very deep. So this one is quite uniquely, right, deeply embedded, right, within the compartment. Okay. And then let's take a look. We have also the muscles. We have to have a good system to work on. So that's why we also have this retinaculum. So we have the superior extensor retinaculum, and also this one like a V shape here, right? The inferior extensor retinaculum. So all trying to tightly like hold all these tendon of the leg muscles. Okay. So that's why here I want to emphasize large area of these, right? They're only covered by the subcutaneous tissue. So make the tibia, particularly the mid shaft here, particularly the mid shaft here is very vulnerable, right, to be broken, right? Okay. So supplied by the anterior tibial artery. Okay. So altogether, these muscles. Now this one gives you a better ideas to the origin. Okay. I will show you this one. Say we have the number 1 here. This one is the tibialis anterior. So these tibialis anterior, very important muscles. Okay. And then we also have the others, right? The number 3 here. The number 2 here is the one to the hallucis. Can you see that? And then for the remaining 4 here, which is to the digitorum. Okay. So altogether, these are to dorsiflex. And this one is to IN version of the foot. Okay. And now, why I highlight this? In this particular part, we just learned about the tibialis anterior. So tibialis anterior can do the inversion of foot. But another muscle, which is called the tibialis posterior, can also perform inversion. Now, this one you have to take note. Why? If you are assessing patients' the ability to invert the foot, if you still see certain degree of inversion, IM version of it, then you have to think of whether the problems is because of the tibialis anterior or posterior, because both of these muscles can perform inversion of foot. Okay, we will touch on this part again in the another injury type. Okay, so what else here? So this is the action to show you the dorsiflexions, right? So all these muscles can help to dorsiflex, right? What you do by dorsiflexion? If you want to feel your tibialis anterior, you just forcefully dorsiflex, and then you can feel the muscle. And if you're doing in this position, you can still feel your tibia still without much muscle covering on it, right? Make you have like, oh, I still got a quite slim leg, right? Not much muscles covering on it. Okay, let's take a look here again. Now, this is the anterior tibial artery, which is running very deep inside of the anterior compartment, right lateral to the tibialis anterior. And then next to it, we also have an important branch here, we call the deep fibular nerve. Okay, I will keep using fibula because I know that in some traditional textbook, you or clinical will use the peroneal nerve. Just keep it simple, fibula, because the bone is called the fibular bone, right? Fibula, the fibular nerve. So this compartment is innervated by the deep fibular nerve and supplied by the anterior tibial artery. Then some of you ask, is there any particular bony landmark that you have to remember? Or as far as I have mentioned in class, then you have to know about them. Okay. So I will try to draw your attention to this. So these anterior tibial arteries supply the anterior compartment of the leg. Where does it come from? It's actually coming from the arteries from the back. Here, can you see that? Remember we talked about the popliteal artery? And then at the back, when they further descend, and then the first, most of the time, the first branch off is to these anterior tibial artery. So it has to pass through an opening on the interosseous membrane. Okay, so this is it. We have the openings here on the interosseous membrane, and then the popliteal artery will then divide it into one branch and then go to the front through this opening. Okay, and then the artery will then further down. So keep on the posterior tibial artery, and then we further divide it into two, the fibular artery. You may ask why the posterior compartment of the leg deserves two arterial blood supply, but not the lateral compartment. Look at the muscles and the size of the muscles. Then you will know why. Okay, fibula, the lateral compartment, literally only two muscles. Okay, but for the posterior part, we will talk about it. There are several muscles, the big one. Okay, then they travel together, and then these anterior tibial artery will become like another vessel called the dorsalis pedis as it cross the ankle joint, right? So this dorsalis pedis is an important structures that you have to be able to tell, right? Because it is important. It is important in many ways. Okay, so let me show you. Where does it? How can you locate it? So these dorsalis pedis are very superficial arteries. It's actually running quite lateral to these extensor hallucis longus. So how can you find the extensor hallucis longus? It's easy. 有冇人除咗鞋嘅？唔係，有冇人冇着鞋？唔係，有冇人除得鞋？Sorry. So, okay. So, so if you want to, you can ask the patient, try to forcefully dorsiflex the big toe. You do it now. Yeah, dorsiflex to big toe. And then you can feel the tendon. You can feel the tendon of this extensor hallucis longus. And then if you find it, then it is actually lateral to these extensor hallucis longus, you can find the pulse. Again, try to do it tonight or on your with your roommate with consent, okay? So you ask, or you do it on your own. You forcefully dorsiflex, and then you will make the tendon very obvious, right? And then here, you just lateral to it, okay. So slightly dorsiflex, and then it is lateral to the EHL tendon. Okay. Now, why you need to bother? It nowadays, well, later on when you go to clinical, many of your patients actually will have like diabetic conditions. One of the complication of diabetic patient is having the blood vessels problem. The circulation will be very poor. How would you check whether the circulation is still all right? This is one of the way. If you still find the pulse, so usually this one, either the nurses or you guys will do it. You want to check whether the circulation is still optimal, right? Still okay. So if it is absent or weakened of the pulse on the dorsalis pedis pulse, it will suggest that we might have some vascular insufficiency, right? So that is something that you need to know. In the old day or in the previous exam, I quite like to ask this one. Very useful, this one, because, okay. So now here you can see the anterior and the lateral compartment of the leg. Mainly this one, I would like to show you or draw attention to. There are no individual blood supply to the lateral compartment, and there are several branches. While the posterior compartment here, you will see that there are actually, we have two, right? And then the dorsalis pedis is actually the distal extension of the anterior tibial artery. When across the ankle joint, and then it becomes the dorsalis pedis, the dorsal artery of the foot. Okay. So talk about the nerve. We have a nerve here called the common fibular nerve. I hope you have never touched on your or hurt your common fibular nerve. But this one common. Then we have one staying superficially, superficial fibular nerve that supply the lateral compartment of the leg. And then we have one that will turn into the anterior compartment and become the deep fibular nerve. Let me show you again. This is the image. Can you see that? Not this one, sorry. Yeah, this one. Now this is the common fibula. This is the head. This one is the head of the fibula. We have the common fibular nerve. Can you see that it swings around the neck of the fibula? And then it divided into two. This one is the superficial branch, supply the lateral compartment of the leg, while another branch will further and pierce through the septa and then go into the anterior compartment here as deep fibular nerve. Can you see that? Okay. So, which means that we have some problems that you need to know how to differentiate. Whether or not the problem is something wrong with this common fibular nerve, or the problem is just dealing with the superficial fibular nerve problem. Or say, for example, if there are, for no reason, there are the anterior compartment syndrome developed, the nerve here, the deep fibular nerve in the anterior compartment will also be compressed. Okay, you know what I'm trying to say? So here give you the different part, right? Superficial to the lateral, deep one, and to the anterior. So this one is important. If you're asking like which cutaneous nerve, which zonal responsibilities that you need to know, this one is what you need to know, because it Again, it covers like several nerves here. Let's take a look. The shown one here, the medial part is quite, the distal extension here, the number one, here we're referring to the saphenous nerve. Remember the saphenous nerve is is the remaining nerve component of the femoral nerve. And then when it pass through the, and then that saphenous nerve, when they would go through the adductor canal, and then we'll go to the skin, the subcutaneous, right? Subcutaneous, and all medial aspect. And then we're down to the medial malleolus. So this is number one. So saphenous nerve, then you have to think of if this saphenous nerve is actually the extension or the distal branches of the femoral nerve, okay? You have to bear in mind with this. And then number two here, the majority of the foot here we are talking about is supplied by the superficial fibular nerve, right? And then it will further become the nerve that supplies the digit, skin, sensation, okay? And then this is superficial one. What about the deep group? The deep fibular nerve is the wedge area between the big toe and the second toe here. So this one is exclusively, right, responsible by the deep fibular nerve. Then you know that why I have to make it so explicit. Because if the problem is the common fibular nerve, then all the superficial and the deep nerve, you may have sensation problems, right? But if the problem is only exclusive to the deep fibular nerve, then when you ask the patient or when you this area, ask for the sensation, then they may feel, I'm okay. I don't feel anything. Okay, so that's why this is it's actually one of the past paper, if I'm not wrong. Yeah, last year or the year before, I can't remember. Okay, so then down to this one, common fibular nerve injury. 咁即係唔考啦，係咪？咁我出 MC 噶嘛。Okay, so then now take a look. This one is the common injury nerve because of it wings subcutaneously around the fibular nerve. Take a look. It's actually very, very superficial. So when you do dissection, please take out the common fibular nerve. Very superficial. Very superficial. And big in size. Okay. So then the cause of the injury could be due to the fracture of the fibular neck. It could be because of the stretch by the knee joint dislocation, or for the girls, when you try on some boot, don't try those like with super slimming effect. If you have the long boots up to this level, I tried that before. 我以前細個都好貪靚，着啲好緊、好高嘅 boot 咧 ，right 喺正呢個位有冇女同學試過拉鏈嗰個位咧？好痛㗎，唔係拉親啲肉喎。Because of the level is quite nearby the swing area, the common fibular nerve, like swing into the compartment. If you damage this nerve, then you have pain. And then you may have the following presentation. Or in some case, if patient need to have like long leg cast, 嗰啲叫咩？打石膏啊。If it is too high, it could be like pinching the nerve, the common fibular nerve. Particularly, I'm referring to these sites here. Very superficial. So what will be the presentation? Take a look. Motor loss, right? You will find that the anterior and the lateral compartment will out of function. Muscle paralyzed. Why? because the following, right? The superficial nerve doesn't work, deep doesn't work, deep doesn't work. Okay? This is the motor function. But with this one is complete loss, not total loss, complete loss, okay? You're still there, you are not total loss, okay? We have partial loss of inversion, IN. Why here is partial loss? Remember the tibialis posterior still functional. Okay, so that forms the difference. Okay, and then for the sensory loss, if we are referring to the common fibular nerve injury, so whatever, for the superficial fibular nerve as well as the deep one here, the sensation may be trouble, right? Okay. Then we down to the posterior compartment of the leg. So muscle, we call it the calf muscles. Okay. So we have the superficial layers. We have three muscles. Big brothers here, the gastrocnemius. This is the medial head, and this is the lateral head. We also have a small one, just lying underneath the gastrocnemius. We have the pentaurus, and then we have the soleus. So soleus, the name is because it's like a fish name. 比目魚肌係咪？Okay, resembles a flat fish. Okay, so the gastrocnemius and also the soleus, they share a common tendon here. The common tendon is either called the calcaneal tendon or Achilles tendon. Achilles tendon. Okay, so we also have a deep layer muscles here. We have four, and then we have a popliteus, we have tibialis posterior, flexor hallucis longus, and digitorum longus. So the whole bunch supplied by the tibial nerve. And then because of the big population there, we have a posterior tibial artery and the fibular artery. Okay. So the superficial group here, where you can feel, 你笑啲女仔隻腳粗，以前咪叫做甲組腳。Okay, gastrocnemius. Okay, so the superficial group actually carry out by about 90%, right? The plantar flexion. How you do the plantar flexion? The plantar flexion, right? Plantar flexion. So you do the tiptoeing. You're tiptoeing, right? And this is actually important when you're walking. When you're walking, you have to have an action that you would like to push against the floor, the ground, and then have some push off effect, and then so that you will swing to the front, right? So this is carried out by the muscles. Why we have this name? Because these triceps surae, we have three heads together, two heads, gastrocnemius together with the soleus. So we have a triceps, another triceps. So the actions here, you can lift the whole body, right? And then control the descent of foot when the foot is plantar flex, and propel us forward during walking, right? During walking, okay? And okay, why I emphasize here, gastrocnemius also flex the knee. How come? Take a look. So these are the gastrocnemius. Can you see that? This is the proximal attachment site. If this one keep relatively fixed, when you contract, then actually you will flex the knee. Okay, flex the knee. So that's why I said gastrocnemius also flex the knee joint, because it crosses two joints. Okay, and so because of the importance of this calcaneal tendon, what if it is fractured? Now, if someone with the fracture or the broken damage of this calcaneal tendon, so probably you will hear a very sharp sound, right? Very loud sound. Okay. So if that is the case, think about all the action produced by the gastrocnemius will be gone, right? No plantar flexion of the foot. Okay. Basically, cannot walk. Okay, without aid, without assistance. So one thing that you need to, we also have these small one here. If we remove the gastrocnemius, you will see the soleus. And then in between the soleus and the gastrocnemius, we have these very elegant muscle, which is called the pentaras. It had a very long distal tendon running here. Can you see? It's running here, right? I understand that for some surgical purpose, they will harvest these pentaras tendon, right, for grafting. Okay? You can check the usage. And this one, again, this one is very important. The calcaneal tendon reflex. When you take the calcaneal tendon, you're testing for the S1 and S2 nerve root, in particular S1. Okay, so the nerve injuries causes absence of the plantar flexion. Okay, so here give you a very detailed arrangement. For those I highlight, right, in particular, this one, the tibialis posterior, it works with the tibialis anterior to invert the foot, and then when the foot is off the ground. And also this is an important member to support the medial longitudinal arch, right, of our foot. Now, what I want to draw attention is on these, the tendon here. So this one, this is, okay, let me see. So this one is the flexor hallucis longus tendon. So this one also important because it can help to like flex the big toe, which is actually a powerful push-off muscles as in walking and jumping. Okay. And also these tendon also important in maintaining the medial longitudinal arch. Okay. Why we emphasize all these support to the arch? Remember, one of the main functions of our lower limbs is to support our body weight. We cannot let the structure collapse. And if you notice that in your foot, there are arch, right? The arch is allow flexibility without collapsing. That's why we need to have different support, ligament, and this is the tendon. And then later on, we'll talk about the ligament, right? The plantar ligament, okay? So one more muscles. These muscle, very deep muscles, is called the popliteals. So these popliteals is important. You can mark here first to unlock the knee. Unlock the knee, okay? So again, here you see the tibial nerve, and then with the posterior tibial artery and also the fibular artery to supply the whole compartment. Now, this I want to draw your attention to quite let me say it this way, interesting presentation is that, okay, running on the posterior leg, we have the small saphenous vein, right? Usually running nearby, we have a superficial nerve, which is called the sural nerve. And this is a superficial nerve supplying the skin of the lower lateral and the posterior and the lateral foot. Where does it come from? This one is quite unique in a way that the origin is from these branches from tibial. And also from the lateral branches here, the origin is from the common fibula. These two join together again, right? Supposedly they are separated, right? But now they join again, right, to form the sural nerve, okay? You should be able to see the sural nerve when you do dissection, quite big in size, okay? Okay. And then this is the blood supply. Remember, we have two. And then the tarsal tunnel structures. This one, take it as take the carpal tunnel as siblings for comparison. The carpal tunnel 得唔得啊？琴日喺度坐嗰個刮嗰個位，OK, carpal tunnel. So this one is the tarsal tunnels. So I try to make all the foot on the same orientation. So that's why you can see in a better way. 我自己寫嘅，因為幅圖係左右調轉晒。Okay, take a look. Take a look. From anterior. Okay, so this is anterior, and this is posterior. Any Tom? Any Dick? Any Harry? No Mary. Okay. So we have the tibialis posterior, Tom, and then we have Dick here, and then flexor digitorum longus, and then we have the AN artery, which is the posterior tibial artery, and then we have the vein. So you should know that these three always come together, right? So we have the posterior tibial artery, posterior tibial vein, and then tibial nerve. And the most posterior one here is the flexor hallucis longus. Tom, Dick, and very nervous Harry. Okay. So here you can see the arrangement. So we have the tibialis posterior, and then Tom, Dick, and very nervous Henry, the muscle, the hallucis here, okay? And so that's why, okay, here is another one. If you want to check the pulse, right, you can make reference with the medial malleolus, and then you can feel, because every single thing is running behind, right, of the medial malleolus, okay? And then here you can feel the posterior tibial artery pulse there. Any syndrome can be developed if there is abnormal pressure built up within the tarsal tunnel. Then it will compress the tibial nerve, and it will causing the medial ankle pain, as well as the numbness in the sole of the foot. How so? In the following slide, we will talk a bit about it. Okay, now this is a very scary diagram, I know. But what I want you to understand is, at least from now on, the leg muscles, right? So we have plantar arches. Why not we all have the we have the arches. It's just like, think about it, our foot here is like a tripod. Tripod. It actually allows like flexibility while we can withstand the pressure, and also some very exaggerated or very like some exercise, right? Weightlifting, etc. Okay. So these arches, we have 3 arches to go. The first one here, you can put a mark there. Medial longitudinal arch is of your most concern. You need to know this, because if these arches is not optimal, can you give the name of the problems, which not Dr. Lau, but another doctor usually get a lot of money from? You don't have, you never visit there to do the measurement? So if this arch is not optimally high enough, then we will develop flat foot, right? So you may have to buy some special cushion, special like adapter to help you to like give more support to the arch. So most problematic one, make a mark here, medial longitudinal arch, okay? So, and then we also have the lateral one, the transverse one, but the most important one is the medial longitudinal arch. Now, this arch how we maintain this arch? We have unique bony structure, and then we also have some soft tissue, the connective tissues, which is the aponeurosis and also the ligament. What I mentioned here is, remember I showed you some of the long tendon actually cross the foot, right? So they actually can also provide support. And that's why I mentioned here, long leg muscles also provide support to these arches. Particularly, I want you to pay more attention to the medial longitudinal arch, 扁平足, okay? So these muscles, because when you use this muscle, you actually will give active support. Now, like when you are sitting now, this muscle basically you're not using it. They are not under contraction or relaxation, no movement at all, no action at all. But when you are using your leg muscles, then these long tendon, right? Remember the long tendon like this one here? They basically cross, right, the foot. That can also provide support, right? That's all you need to know so far for this slide. And then this one, if you have to stand or walk or hiking for a long time, have you noticed that these 3 points, where we say that is the main contact points of the foot doing weight bearing, is actually these 3. You may find it quite painful. Yes. Why? Because we are not the duck feet. Like all surface of your foot like touch on the ground. These 3 are the main contact points, right? When we talk about the arches and everything's here, okay? So as I say, the foot here we refer as the function is like a tripod here, okay? So the weight is transmitted through these 3 contact points. So this supports a balanced pressure distribution, okay? And if we have abnormal arches, so this one is a normal. If you have too high, or quite a number of us will have a fat foot here, okay? So if that is the case, then these contact points, right, you may feel more pressure because of the imbalance about the body weight distributions, okay? And yes, this one, you need to pay attention. Flat foot, we are talking about the low medial longitudinal arch, right? Could be due to like insufficient support of the muscle tendon, okay? So this one, the palmarus longus. Here we have the palmar aponeurosis. So yesterday we have the palmar aponeurosis, here tarsal aponeurosis. Very similar. Okay. So the sole is covered by the fibrous subcutaneous tissues, which is called the plantar aponeurosis, right? A central thickened plantar fascia. It protects the plantar surface as a shock absorbing pad. So that's why quite a lot of fat. Okay, I can share with you, you got no way to dissect the sole in dissection particle because we don't have time. If you want to dissect it, at least you have to days as a unit, not hours. Think about yesterday when you do the palm. This one is super difficult. But so that's why this one you have to take a look on the prosthetic specimen, okay? So, but this one also help to support the longitudinal arch of the foot. Now, what troubles us, not you, later on when you're getting older. So some people may complain, 好痛啊隻腳, right? Plantar fasciitis. So particularly when you wake up in the morning, you wake up and then you step the first step on the floor, you will have like sharp pain, okay? The plantar fasciitis is actually referring to the inflammation of these plantar aponeurosis It causes pain and tenderness of the sole and foot. Now, yesterday, some of you are very ambitious and say, I want to see the lumbicals. I want to see the intrinsic hand muscles. So do you have to know all these muscle for the foot and sole? No, you don't have to. Okay, good. But you need to know some conceptual understanding. Is that there are two vascular plans. Okay, so if you remove the skin and then remove the aponeurosis, the plantar aponeurosis, you will see these as the first layer of muscles. Right? We have the second layer of muscles, and third and the fourth. So what you need to know is in between these two layers, we can see neurovascular bundle. That's all. And then in between the layer 3 and layer 4, we have another neurovascular bundle. That's all. Good. Unless you want to get a ticket to play and earn money in circus. Use your foot to hold the chopstick, I don't know, to draw. So neurovasculature of the soul is here. So remember the tarsal tunnels. We have the tibial nerve, right? So when it passes through the tarsal tunnel, then it becomes two major nerve here. We have the lateral plantar nerve, and then we have the medial plantar nerve. Okay, so these medial and lateral plantar nerve, where we can find it is in between the first and the second layers of muscle. That's all I want you to know. Okay, and then so the lateral side, and then further descend to the lateral part, and then it will further divide it into the superficial, and then another one here, which is the deep branch. Okay, and then on the medial side is further descent, right? And then it will then become the digital nerve, right? This one, just for your information. What you need to know is this one, the branches, right? So, yes, this one is quite similar to our ulnar and also the median nerve, like the function you can find in for the upper limbs, right? So on the side here, we have the lateral plantar nerve, where we say is quite similar to the ulnar one, and with the medial plantar nerve, which is like a analog to the median nerve, okay? So it supplies all the intrinsic muscles in the plantar regions as well as the skin of the sole. Okay. So which means that if there is like compression in the tarsal tunnel, what you may think of is whether or not these plantar nerve, medial or lateral one, would be trouble. Okay. And we have the palmar arch. We also have plantar arch. And these are forming like a network here. Can you see that the network, the lateral plantar artery, and then it will form the plantar arch. And then actually there is a anastomosis formed with the dorsalis pedis artery. Remember the dorsalis pedis artery is from which is the termination of which artery? Anterior tibial, remember that? The anterior tibial. And then actually it formed the anastomosis with the one actually coming from the posterior tibial artery, and then later on to the lateral plantar artery, and then there is a connections here. You can take it as like an anastomosis, okay? Just like your palm, right? Radial and ulnar, forming the arches, okay? Oh, just lecture 4, how come? So this is lecture 5. So please take a look at the knee structures. So knee is the most complicated hinge joint, okay? And it's so important for us to, whether or not to stand, to walk, and to run, right? Please have a look on the, may I invite you all to have a look, go to the Complete Anatomy apps to take a look on the, like, the knee, the ligament, right? The knee ligament arrangement. Because the knee joint is very complicated, you need to know about the soft tissues. There are two groups of soft tissues. The first group is these ligament here, right? The ligaments here. And also this ligament, we have how many ligaments? 1, 2, 3, and 4. They are ligaments. So these are running collaterally across the joint, and some inside the joint, right, forming a cross. So that's why we have the anterior cruciate and the posterior cruciate ligament. What's more, we also have this cushion here. So this cushion is called the, what does it call? Meniscus. Meniscus. Then please go home and have a look on this arrangement of the meniscus with relation to the nearby ligament. I highlighted it here already. Can you see the gap here? So this lateral collateral ligament is quite standalone. Can you see that this is the medial collateral ligament, tightly, right, connected with the medial meniscus? This is one of the important reasons, right, for why this medial meniscus is more prone to be damaged in many types, in different types of injury. Take a look. This LCL is like a standalone cord-like materials with an empty space. And this one tightly connected, contact with each other. Can you see that, this one? Okay, so that's why I give you some big pictures. That is my purpose. So the medial or the tibial collateral ligaments, this one is very broad, attached to the capsule and attached to the medial meniscus. Tightly like attached to it, which is good to offer protection, yes. But sometimes if it is too tightly attached to each other, one of them is being damaged and the other will be also affected. Okay, so it helps to limit the full extension and thus aiding the locking system. And this one is the lateral collateral ligament. This one is the cord-like materials. You can highlight these as well, not attached to any joint structures, very standalone structures. Okay. And also please go home and take a look. So what we call the normal alignment of the knee. So this is normal. And usually you may see people like walking in this way. 隻腳好似個波形咁嘅樣，記唔記得啊？啲老人家咧，記唔記得啊？隻腳 okay, it's like tilted or turned inward a little bit, right? And for this one is called the valgus, and this one is called the valgus, like a lock knee, right? Okay. Definitely, either the valgus or the varus one, you will change the LOC, the line of gravity, a lot, right? Remember the lecture one? We talk about the gravity. So if any misalignment here, the line of gravity will change as well, okay? So strong LCL, MCL prevents side-to-side movement of the knee when the knee is fully extended. We want to, so I will finish very soon. This just on this slide. We want to stand very firmly on the ground with minimal effort. How to make it happen? We need to lock the knee without side to side movement. You have to lock the knee. While the force can, like with minimal effort, we can stand and withstand the weight, or you are uplifting something, right? So that's why it is for the knee joint. Think about the locking system. The locking system. So if you can really do some home reading, please go to, so the link doesn't work, but the QR code is still functioning. Please go home and scan the QR code. It is actually a YouTube video, but I want you to focus on these timestamp. Okay, you can go home and have a look. Okay, this one showed you the locking system, how to lock the knee and unlock the knee. Okay, I think I will stop here, and then I will update you for the remaining recording. Okay, thank you. Stop. I see.